Hello everyone and welcome to another case in the series of emergency medicine. Today we will be talking about hypertensive emergency. So let us start. So first of all we want to know what is the difference between hypertension, emergency and urgency. I have drawn a simple chart to explain that what is the main difference. Hypertensive emergency, as you can see, that the systolic blood pressure should be more than 180 or diastolic blood pressure should be more than 180, and same goes with urgency. So then you can label it any one of them, but the main difference is that the end organ damage is present or not. If there's any end organ damage, it is hypertensive emergency, and if there is no end organ damage, it's urgency. What does mean by end organ damage? Any symptoms affecting CVS, CNS, kidneys, eyes, means the patient have chest pain, dyspnea, pulmonary edema, increasing creatinine, urea, papilledema, confusion. So these are the presentation with hypertensive emergency. So how would you manage hypertensive emergency? We need to manage it acutely. We need to lower down the BP over hours. But in the urgency, we need to treat it gradually over days because there's no end organ damage. So what will be the goal of BP in both? In urgency, it's easy. Over days, you need to gradually decrease it. But in emergency, your goal would be first that you need to decrease the mean arterial pressure MAP in the first hour 20 to 25%. Then in the next 2 to 6 hours, you need to decrease it till 160 to 110. But except ischemic stroke, because we need that blood vessel to supply the blocked artery in the brain. So that's why we keep the blood pressure high in ischemic stroke. And in next 24 to 48 hours, we need to decrease it to the baseline. So this is a simple chart which will help you in differentiating hypertensive emergency and urgency. So next, how would we treat such case? We will be talking about emergency. So first of all, an adult presented with sudden onset high BP with presentation of any end organ damage, chest pain, dyspnea, headache, confusion, papilledema, increasing urea, correct. So once it presentation and the systolic BP is more than 180 or the diastolic BP is more than 120, your goal will be always with the ABCs, and then the circulation. In circulation, what you need to do is you need to pass an IV cannula or you need to pass an interarterial line to continuously monitor the BP. The most important part here is you need to continuously monitor the BP. Next will be the vitals, and then sending the labs at the same time to know whether the end organ damage is being present or not. So our goal will be selecting the appropriate antihypertensive medications. Most safest is injection labetalol. We need to give the patient with 10 mg to 1020 mg IV stat over 2 minutes, and then repeat the dose after 10 minutes until desired target is being achieved, up to 300 mg. Next, we will be selecting if the labetalol is being contraindicated or it's not present, depending on the institution, the injection hydrolysine 10 to 20 mg IV diluted in 9 ml 0.9%. Normal saline over 5 minutes to 10 minutes can be given, and it should be repeated until the desired BP is being achieved. The next one is sodium nitroprusside. but in our institution we use it quite less often. So because it produces a cyanide toxicity, and with a dose of 0.3 to 0.5 mg microgram per kg per minute. So these are the three main medications which we use for the management of hypertensive emergency. But you want to know about the disease. Let's suppose a patient came and he had aortic dissection. Then you can select any one of the medication from here, like labetalol or esmolol. If the patient have an AKI, then phenoldiazepam and nicardipine can be selected safely. Patient have acute ischemic stroke, and then we need to manage it. We need to manage it by labetalol and nicardipine, also in intercerebral hemorrhage. Next is eclampsia and severe preeclampsia. Labetalol and hydrolines should be selected safely. Then the pulmonary edema, nitroglycerin, nitroprusside safely should be selected. Next will be the ACS, and then the most important one is if you have an sympathomimetic drug toxicity. So not any one of the drugs is being used. The most likely one is used is benzodiazepines. So in managing the emergency hypertensive emergency, you need to know if the patient have any disease present before. If not, then you can select any one of them, but if it's present, then you need to be cautious about selecting any antihypertensive medications. So thank you for watching. Like and subscribe my channel. Thank you.